joining from such diverse backgrounds in the chat room. So kudos to you all saying who you are and where you're from. Next slide. So I'm Justine Turner. I'm a pediatric gastroenterologist for those of you who don't know me, and I'm the medical director for the Pediatric Home Nutrition Support Program in Edmonton and co-lead for the PEAS project. And May is Pediatric Feeding Disorders Month. So there is a new diagnostic term, as you know, that we should be using, especially for those of you coming on into Connect Care now. Using this term will help us raise awareness, support families, empower professionals, advance the system of care and research for pediatric feeding disorders. So please use the code. Okay, next slide. So to begin with, we should acknowledge that our work is conducted on the territories of Treaty 6, 7 and 8 and the home of the Métis. We acknowledge that many Indigenous communities have been forged in urban centres across Alberta. We respect the treaties that were made on these territories, acknowledge the harms and mistakes of the past, and dedicate ourselves to moving forward in partnership with Indigenous communities. Next slide. So a couple of housekeeping items. If you have comments during the presentation, we welcome you to write them in the chat box and select all panelists and attendees, as many of you are doing. We'll also have time for questions at around 2:50, so you can use the Q&A or raise your hand if you have questions at the end of the presentation. We'll wrap up the main session at 3 p.m, but we're very lucky that Dr. Rosen has agreed to provide us an extra 30 minutes of her time to have a percolator. So you'll have the opportunity to ask many questions around her presentation or other concerns you have around GI issues and feeding disorders. Next slide. So remember, registered participants who attend this webinar will receive a certificate of attendance. Next one. So many of you know this now, but of course the Pediatric Eating and Swallowing, or PEAS project, is a provincial quality improvement initiative with the purpose of developing a clinical pathway to standardise and improve the care of children with paediatric feeding disorders in Alberta. For this phase of the project, our target population has been children in ambulatory care, and many of our resources focus on outpatient and community care, but they can also be easily applied and adapted for other settings such as acute care. And I hope you're all familiar with our website, as shown here, peas.ahs.ca. Okay, so I'm absolutely delighted to introduce Rachel Rosen, who's a pediatric gastroenterologist who's going to speak to us today about feeding disorders and intolerance. She is the director of the Aerodigestive Center at Boston Children's Hospital and is an Associate Professor of Pediatrics at Harvard Medical School. And she has been extremely active in advancing research and knowledge in this field. And that has truly improved the clinical care of children with aerodigestive and feeding disorders. So I'm very excited to hear her talk today. Thank you, Rachel.
Thank you so much for having me. I'm going to share my screen now. Can you guys see it okay? All right, great. Well, thank you for inviting me to speak. As Dr. Turner mentioned, I've been doing this a while, but as a result of that, sometimes it comes with a bit of a biased perspective. So please feel free to chime in the chat or in the discussion if your experiences are different. And I acknowledge that that some of these areas are a lot of art of medicine, sometimes a little bit more than the science. All right, so to get started, pediatric feeding disorders, as Dr. Turner mentioned, are extremely common. And this is one of the first studies here in the US that actually tried to get a handle on how commonly we see pediatric feeding disorders. And as you can see, no matter which database you look at, a private insurer or public insurance here in the US, rates of pediatric feeding disorders are going up. And we're seeing this in our GI clinics as well, that many kids are presenting with feeding complaints as their first touch point with us. as a gastroenterologist, probably the most common thing that I get asked is this reflux contributing to the feeding disorder? And I'm going to show you 3 videos of kids from our clinic. The first one that I'm going to play is a kid that was referred to us for a severe reflux and was told that they had Sandifer syndrome, which is reflux bad enough to cause neurologic behaviors. Our little friend in the middle was felt to have reflux as a cause for their junky breathing and pulling off the bottle. And then our last friend was told that they had choking relating to reflux. So just to give you some idea of kind of what we're seeing, and this kind of discomfort with feeding was felt to be related to reflux in all of the cases. Here you can see kind of the pulling off of the bottle. And then our little kiddo who's choking and coughing during feed. So fairly typical for our aerodigestive clinic and for our gastroenterology clinic. So when we think about kind of the big 3 reasons that kids are referred to us, it's number 1, probably 1 through 20 is rule out reflux. And then we get asked questions about allergy, and then oropharyngeal dysphagia or aspiration, and then other potential causes. And we'll talk a little bit about those. But let's kind of get reflux out of the way because it's the most common thing we see. So we are very, very hesitant in our clinic to diagnose gastroesophageal reflux disease. And the reason is because once that diagnosis has latched on, it then becomes the basis for escalating care, many of which are ineffective changes in care. And we'll talk a little bit about the data for that. But this was a study that was done where they asked families little vignettes about their child, and it says, you know, you have a 2-month-old child who is irritable, and we have a medicine that may work or may not work, or we have a medicine that is ineffective. Do you want this medicine? And when the child was just a fussy child, more families were ambivalent about getting a medication. But when you give the exact same vignette and you say you have a 2-month-old who's fussy and they have gastroesophageal reflux disease, we have a medicine that's ineffective, do you want it? Many more parents want that medication, even when you say it's ineffective, because they have that tag of GERD or gastroesophageal reflux disease. So just by giving somebody the title of a disease, you're more likely to want a medicine. And I think that that's really important, especially when we talk about the antacids and why they're not effective. So again, just be careful what you label patients. Apart from that, there's a lot of folks who kind of look at the kids and say, oh, I watch them feed and they're so irritable. I really think that you have reflux, therefore I'll prescribe a proton pump inhibitor. And I think it's important to know that we all are pretty terrible at diagnosing reflux. And this is one study where they had babies who had probes, reflux probes in their nose to measure reflux events. And then they had people blindly score videos of patients to say, were they uncomfortable? Yes or no? Were they retracting? Did they have signs of reflux? And what you can see is no matter what the symptom that typically is attributed to reflux, about half the time there was reflux in the esophagus, but half the time there was nothing in the esophagus. So really your ability to diagnose reflux based on visualization is no better than chance. So again, just you can't rely on observed reflux episodes to diagnose reflux. We also know that giving a consistent message matters a lot in the hospital. And this was a study that we did looking at children with brief resolved unexplained events in our hospital. And one of the things that we were finding was that a large number of kids in the hospital were coming out on proton pump inhibitors. And we really wanted to try to see where this was emanating from. And what we found was that all of the consultants that were consulted on the patients had a big impact on proton pump inhibitor prescribing. So if there are speech language pathologists diagnosed reflux based on the clinical feeding evaluation, kids were much more likely to come out on a proton pump inhibitor, or if the lactation consultant diagnosed reflux. So you just have to be careful about the wording. So if you feel that it is reflux, talk to the team members before you mention it to the family to make sure everybody agrees that that is the diagnosis, so we don't unnecessarily prescribe therapies. Now, the reason we know a lot of this relationship between feeding issues and reflux is because we've been able to use multi-channel interluminal impedance, which is our way of measuring reflux in infants and kids. And you can see I circled in the middle. This is what a probe looks like when we put it in older kids and in infants. And the beauty of this is it measures both acid and non-acid reflux. And this is really important in kids, this non-acid versus acid distinction. And I just kind of want to highlight what happens in babies in particular. On the x-axis, you have time from a feed. So this bar represents 0 to 60 minutes after a feed. The next one is 60 to 120 minutes, and then 120 to 180 minutes after a feed. And what the investigators did was they fed the babies, and then they just looked at the percent of reflux after meals. And what you can see is in the first 1 to 2 hours after a meal, the majority of reflux episodes are actually non-acidic. So you can put all the proton pump inhibitor you want into babies, and it's not going to do anything because what's getting refluxed is not acid. And again, I think this is really important because you don't want to treat kids with medicines that don't help. So based on our impedance studies, we know that non-acid reflux is really common in kids, particularly in the postprandial period. Now, when we look at the pediatric reflux guidelines, and let's say, you know what, I don't care what you're saying, Rachel, I want to treat, I think this kid has reflux, what's the first step that we would recommend? And in the guidelines, we recommend thickening feeds and avoiding overfeeding. And I want to talk a little bit about thickening of feeds because when I think about where the field of management of gastroenterology, gastroenterological symptoms are in pediatrics, it's really in nutrition management. And we'll talk a little bit about how our perspective has changed a lot. So let's talk about thickening and the evidence behind it. It's first-line treatment for reflux if you think the baby is having reflux. And we know based on, this is a study from 2008, but I think it's very nicely illustrates what we see, which is thickening improves weight gain and it reduces the number of regurgitation or reflux episodes seen per day. So we know that thickening works from a reflux perspective. We'll talk about how it also helps with oropharyngeal dysphagia, but from a reflux perspective, it's a pretty good therapy. When we started with the reflux guidelines, what we said was add a teaspoon of cereal per ounce of formula, and that's how you thicken for reflux. And we kind of look back on those guidelines now and cringe because we know so much more about thickening than we knew back then. And you have to be really selective on kind of what thickeners you pick. So do I need calories? That will change what thickener I pick. How thick do you want to make it? Now that we can IDSI test it, and hopefully in the question and answer, we'll talk about how IDSI testing has really changed our pediatric gastroenterology practice, but now I can figure out in the clinic how thick I actually want things to be. Do all formulas thicken the same? We'll talk about that. What do you do if the kid is breastfed? We're using a lot of commercial thickeners in infants under the age of 1. Can the child get the formula or breast milk out of the nipple? Another really key question. You don't want families cutting nipples and converting a baby to an aspirating baby. And then a variety of other considerations to consider. So thickening, the sky's the limit on thickening, and not only is it important to thicken, but thicken within cultural sensitivity. So there's lots of different things that we use to thicken, and we are very creative. Sometimes our clinic looks a bit like a kitchen when we work with families on what works best for their family structure. It's really important not only to know what to use as a thickener, but how that thickener behaves over time within the construct of the family. So for example, if a child's going to daycare in the morning and the family's mixing up the whole batch of formula or breast milk in the morning, you need to know what that formula or breast milk is going to look like at 3 in the afternoon when that last batch gets fed to the patient. So I put up here one example of a study in Pediatric Journal of Pediatric Gastroenterology and Nutrition that I think beautifully highlights that not all thickeners are created equal, and over time some of them really end up looking like sludge. And so when you recommend a thickener for reflux, you need to know how it will behave long term. You also need to know how it will behave in the context of the patient. So bashing a lot of acid suppression. And here's another reason why I don't like antacids is because if you're using an anti-reflux formula, for example, those are activated by having acid in the stomach. And if you get rid of the acid, then you negate the properties of the thickening in the stomach, for example. But even more complex than that, when you're doing a combination of formula and breast milk, you need to know how your thickener behaves. So for example, on the bottom, you can see different anti-reflux formulas. And you can see, for example, Similac Spit Up or Enfamil AR. And when you add acid to them, they thicken really beautifully. Their viscosity goes up as it's supposed to. But then if you add even just a little bit of breast milk to it, then the formula will no longer thicken. So again, if you're going to use an anti-reflux formula, you want to give that separately from any breast milk feeds that are going on, so you preserve the benefits. And you don't want to give an antacid that will get rid of the acid that's needed for thickening. So again, just knowing all of these nuances of your thickeners is really important. Adding even more to the complexity, what you also need to think about is the caloric content of the calories, the caloric content of the formula. And again, I can't give enough of a shout out to multidisciplinary care, working both with gastroenterology, nutrition, speech language pathology, and occupational therapy to come out with a plan that works best for the family, but that's also safe. So just to show you on the left side, on the y-axis, you have osmolality. And then on the x-axis, you have the recipe for amount of thickener added per ounce of formula. And what I want to highlight is that when you look at 22 calorie per ounce formulas and then you add thickener to it, that's very much within the safe zone for osmolality for kids. But once you start going to the hyper concentrated formulas, you get above the AAP, the American Academy of Pediatrics safe zone. So you really need to know not only what thickeners you're using, but what caloric density formula you're adding it to. Now, I'm a motility person, and so I care a lot about gastric emptying. And on the right side, you can see the impact of differing caloric densities on gastric emptying. So the higher you go with your calories, the slower your gastric emptying may be. So if you have a kid that has feeding intolerances, vomiting or spitting up, sometimes the instinct is to go to higher calorie formulas to get them on less volume. But in fact, that may worsen their gastric emptying and make their vomiting worse. So you just have to be cognizant of what all of these things that you're adding or adding to your formulas, the impact of it on a variety of different factors, not just, on calories, but not considering the impact on motility. And even more complicated is the impact of these medications that we use in infants in particular on the osmolalities. And it really matters because if you're using different thickeners with different caloric density feeds, and then you're adding very high osmolality medications, you can really impact feeding tolerance. So for example, adding iron or adding sodium chloride supplements, which we see frequently in infants, all of those can get you above the American Academy of Pediatrics safe zone. So like, I don't want to mix medications in with my bottle because that may make kids spit up even more or have delays in gastric emptying, for example. So you just have to take into account not only the feeds, but also what medications the kids are getting. And what we know now is in kids that are particularly volume sensitive, sometimes you even need to thicken the medications. And so frequently we hear complaints, my doctor started me on omeprazole or on famotidine, but every time my child gets it, it triggers them to vomit. And what you find is that they're on thickened liquids, for example, but then they don't thicken their medications. So they're gagging and vomiting on their medications because it's unthickened, and potentially they're aspirating on their medication. So there are lots of published charts on how to effectively thicken medications, and some medications thicken better than others. So you just have to keep that in mind for your kids who are very sensitive to different textures. The other thing to keep in mind is that thickeners often have additives that can be complex when you have kids with medical complexity. So I just put some of the nutrition labels that you can see up here, but some of them have potassium chloride added, some of them have added calcium, and all of these different things may impact their health in other ways. For example, if you have a baby with congenital heart disease, you may not want to be giving them all of these electrolytes. So again, you just have to keep that in mind and know what's in your thickener. Now, one of the things that we hear from families is, I was recommended that my child take a rice cereal thickener, but I don't want to do that because my child will get constipated. And I think it's really important not to set the expectation that constipation is going to happen. In this study out of CHOP, they looked at how frequently constipation happens in kids on thickening, and 80% of kids on rice cereal, which people typically think of as more constipating, actually did not have any significant straining. So the majority, the likelihood is the baby's going to have no issues with thickening at all. And even in the kids that did have some constipation with the rice cereal, when you switch them to an alternative thickener, they improved. So again, just to not kind of set yourself up for failure by talking about poop problems when it may not happen. Now, that having been said, even though thickening is really our top 10 things that we do, there are still some patients or providers who want to prescribe a proton pump inhibitor for reflux. And I just want to try to convince you why we hope that that's not the case. We know from old studies, this is a lansoprazole versus placebo, looking at the impact on a variety of outcomes, including feeding refusal, showing no benefit of a proton pump inhibitor over placebo for feeding outcomes. And for fussiness, again, another trial looking at placebo versus omeprazole, showing no benefit in omeprazole for any of the symptoms that we typically think of, such as fussiness or crying. Now, sometimes we get asked to start a proton pump inhibitor because there's this idea that if we have acid-related issues, that will somehow impact swallowing, and therefore, if we heal up any inflammation, then swallowing function will improve. And this was actually a study that addressed that, looking at a variety of different motility parameters, and the impact of proton pump inhibitors on swallow mechanics, showing no benefit of proton pump inhibitors for swallowing dynamics. So again, kind of just debunking this idea that antacids are needed to for infant swallowing, to improve swallowing in the fussy or irritable infant. Now, apart from that, we also know these medicines have side effects, and the side effects can be infectious. And in aerodigestive, we worry a lot about respiratory infections. So we know that proton pump inhibitors and H2 blockers can increase your risk of upper respiratory tract infections and pharyngitis and pneumonia. So if I'm worried about respiratory symptoms to begin with, the last thing I want to do is put on another medicine that might impact their respiratory status. But it also can affect other things like GI bugs, so gastroenteritis, C. diff, and then necrotizing enterocolitis. So again, you just have to be aware of what these medicines are doing. You know, one of my old teachers said, you know, you have acid for a reason, and that reason is that it kills bacteria and viruses. So you just have to be very cautious about these drugs. We also know that these medicines don't seem to improve other disorders that are associated with feeding trouble. So, for example, laryngomalacia in babies. We have lots of babies with laryngomalacia, and many times when otolaryngology looks in their airway, they say, oh, the airway's red. Let's put the kids on proton pump inhibitors to try to improve their breathing. If we can improve their breathing with proton pump inhibitors, we'll prevent them from needing surgery like supraglottoplasties. But in fact, when we looked at this at our institution, what we found was, in fact, that kids who are taking proton pump inhibitors actually went on to supraglottoplasty at higher rates and really didn't improve swallow function at all. So that idea that for kids with noisy breathing, infants with noisy breathing, that proton pump inhibitors help still has not been found to be true. So again, no indication for kids with respiratory symptoms. Now that we're still amidst this pandemic, the other thing just to highlight is that there is some data to suggest that acid suppression, at least in adults, is associated with more severe COVID disease. And so now this combined with some other older studies suggest that proton pump inhibitors do change your risk of viral infections. And we know this is also the case with adenovirus, norovirus, and other viruses as well. So just keep that in mind, that this is not just a bacterial phenomenon. The other thing that we're finding is proton pump inhibitors are associated with the development of allergies. And this was a large study looking at patients who developed a variety of different allergic diseases and whether they were on H2 blockers or proton pump inhibitors during infancy. And in fact, proton pump inhibitor use was associated with the development of a variety of different allergies, including food allergies. And the reason I care as a gastroenterologist about food allergies is because of the concern for eosinophilic esophagitis. So from a feeding perspective, what makes us most worried is, do I need to do an endoscopy? Because is there a chance that this child who has feeding issues does have eosinophilic esophagitis? And in fact, when you look at the study from Journal of Pediatric GI and Nutrition, in fact, the use of proton pump inhibitors was associated with the development of eosinophilic esophagitis later in childhood. So, and those kids ultimately present in older childhood years with dysphagia. So I don't want to take a kid who might have a little bit of reflux or a little bit of regurgitation and then convert them to a lifelong eosinophilic diagnosis with the symptom of dysphagia. And then just to mention fracture risk, I only mention this not because it necessarily impacts your feeding issues, but it's something to think about because many of our kids, for example, are on inhaled steroids or swallowed steroids for respiratory symptoms. And the combination of steroids plus proton pump inhibitors, we worry a lot about bone health. So again, just these drugs affect a variety of different symptoms. Okay, but if you really want to treat, and I hopefully have convinced you that proton pump inhibitors are not your drug of choice, what could you use to treat reflux? So our first choice that we used to use a lot was a macrolide, so erythromycin, which is an antibiotic, but in low doses causes antral contractions, so causes the stomach to contract to hopefully improve gastric emptying. And what we now know from this study from 2018 is that erythromycin is no better than placebo in the treatment of reflux and reducing the number of reflux episodes. So this was unfortunate because we use a lot of macrolides and now we have evidence to suggest it's not beneficial. So what else can we use if we have a kid with feeding intolerance that we're worried about reflux? One of our newer drugs that we use is prucalopride, which is a 5-HT4 agonist, which is like cisapride, for those of you that remember cisapride. It's no longer on the market here in the US, but you can get it in other countries. And this was a study that we did looking at upper tract outcomes. So just to be clear, this is an off-label use of a medication that's approved to treat constipation in adults. And what we saw is that feeding difficulties and reflux symptoms improved significantly in kids that were given prucalopride. So again, treating motility may have benefits from a feeding perspective. The other thing that we think a lot about is other ways to improve motility, and using pyloric Botox is one of them. So for example, if I'm going to do an endoscopy on a patient that I'm worried about eosinophilic esophagitis and they're having lots of vomiting and feeding intolerance, at the time of my endoscopy, I want to maximize what I do. So not only do I want to look for a diagnosis, but if I can treat something, I will. And so when we give pyloric Botox, especially in young kids, and this was a study where the mean age of patients was 3 years old, what we found was that we could significantly improve symptoms of reflux and vomiting and poor oral intake by giving kids pyloric Botox. So this was encouraging to us as another tool in our toolbox for kids with significant feeding intolerance and feeding disorders. The other thing that we found in this group is that we also can change the way kids are fed. So not only do we improve feeding tolerance, but we can get kids, for example, from post-pyloric feeds to gastric feeds by giving Botox, or we can improve the amount of oral feeds that they're taking. So it's not an all or none phenomenon. We can see incremental improvements in how they're being fed if they're fed enterally. We also know that cyproheptadine is another medication. What we use cyproheptadine for from a gastroenterologist perspective is to improve gastric accommodation. So this medication relaxes the stomach so it can hold more volume. It does not have any benefit from a motility perspective. It's really just accommodation. But in this study from our group, we did find that there was improvement in a variety of upper tract symptoms in patients that were given cyproheptadine. Now, from a feeding perspective, we get the added bonus that it might improve appetite as well, but especially for the kids that are volume intolerant, so they only can take 30 cc's or only can take 90 cc's when they should be taking closer to 180 cc's. Cyproheptadine may help even in kids who are entirely fed by gastrostomy to help with feeding tolerance. All right, so the other thing on our algorithm for pediatric GI when kids come to us with feeding difficulties or possible reflux or feeding intolerance is, could this be a cow's milk protein allergy or an allergy to other foods? And I'm going to show you the data on that. And I think there's rarely studies that come along that are so great that I think they should be read. And this one by Tahir Omari in Journal of Pediatrics is one of those. And this is a complex study, but I think it's a really important one because it shows the complexities of overlapping symptoms with reflux and cow's milk protein allergy. So this was a study where they took infants who were irritable and had feeding difficulties, and they randomized them and measured their amount of reflux that they had, and they did extensive symptom diaries. And their goal was to try to tease out what was reflux and what was cow's milk protein allergy. So first they did a pH impedance study, which is the reflux testing that I showed you while the child was taking cow's milk protein. They then stopped the cow's milk protein and repeated the probe again in the kids to measure how much reflux there was when they were off cow's milk protein. And then what they did was they randomized patients to either being on or off cow's milk protein to monitor things like symptoms. And what they did was they categorized patients based on that initial cow's milk protein restriction. If the symptoms went away when they took out cow's milk, those were considered cow's milk allergic kids. If your symptoms didn't get better, then those were considered to have non-cow's milk allergy. And this will become important when I show you the next slide. So they categorize patients into two groups, those with allergy, those without allergy. So that's what you see on the top, not cow's milk protein allergy, cow's milk protein allergy. And what they found was that when they restricted the cow's milk, even in the kids without the allergy, their IGER scores, which are their reflux scores, improved. So there's something about cow's milk restriction that seemed to improve reflux symptoms, even in kids that didn't have allergic symptoms. We also know that in kids who had cow's milk protein allergy and then they outgrew it and went on to regular cow's milk and they seem to be doing fine, that cow's milk in those kids behaves differently and that those kids get more reflux even when they've seemingly outgrown their cow's milk allergy. So in this study, they took kids who outgrew their cow's milk allergy, and then they randomized them to get either amino acid-based formula or cow's milk formula. And they did this while there was a probe in place to measure the amount of reflux they had. And when the kids who used to have an allergy but outgrew it were exposed to cow's milk, they had significantly more reflux than when that cow's milk was eliminated. So again, you can have some long-lasting impacts of cow's milk allergy that may not be apparent just by talking to the family or taking a history. Now, that all sounds well and good. I'm telling you that cow's milk protein restriction may be important, but there's complexities here, right? Number one, we're in the midst of a dramatic formula shortage of elemental formulas, which is a huge problem for us here in the US. But then the other thing to remember is hypoallergenic formulas do not thicken the same way as other formulas. You can pour all the cereal you want into EleCare or Neocate, and they do not thicken. So if you're going to go through a hyperallergenic pathway, you need to thicken with commercial formulas. And I think, again, this just gets back to you need to know what formula you're using and what thickener you're using, and use the right one for the formula that you pick. So just to keep that in mind, that while sometimes we use these hypoallergenic formulas, it definitely adds complexity when you need to use thickeners. All right, so as I mentioned, I love thickening. We thicken everything, and we use a variety of different thickeners, and we like it because it not only is treating reflux, but if I'm wrong about the diagnosis of reflux, I'm also going to improve the kid's swallowing function. And so let's talk about that data. So we have here at Boston Children's, we actually had to open an Aerodigestive consult service on our inpatient team. And the reason we had to open this consult service is because we were getting so many consults for rule out reflux as a cause for respiratory symptoms. And all of these kids were ending up on antacids. We kind of had to shut down some of the acid suppression use. And what we know now is that these symptoms that were typically thought of as cough, thought of as reflux, like cough or gagging or choking or apneas or desaturation, these are all can be symptoms or signs of aspiration or oropharyngeal dysphagia with aspiration. And I think we've learned so much about this in the last 5 years, and there's just this growing body of literature to support how kind of pervasive swallowing issues can be, particularly in infancy and kids. We also know that silent aspiration is really common. So again, just like we can't watch a baby feed and diagnose reflux, watching a baby feed to diagnose aspiration is just not sensitive enough. And in the study that we did looking at kids with brief resolve unexplained events, what we found was the most common testing abnormality in these kids with blue spells was an abnormal video fluoroscopic swallow study. So 72% of our swallow studies were abnormal in this population. And when we compared the results of video fluoroscopic swallow studies to observed feeding, what we found was that the sensitivity of observed feeding was only 43% for diagnosing aspiration. Again, just because aspiration is so commonly silent in the pediatric population that you just cannot predict it by observed feeding. So important to think about further testing or studying in these patients. Now, one of the things that we get a lot of comments about when we try to publish papers in this area is this concept that aspiration is normal and penetration is normal, and kids will just outgrow this, and this doesn't cause any harm. But I think our group here, as well as others, for example, at the Mayo Clinic, have really shown that that's not the case. We're seeing bronchiectasis or chronic lung damage in infants less than a year of age, who are allowed to continue to take formula or breast milk that's not thickened. So that's concerning to us. But also just from a symptomatic perspective, patients just do better when you thicken. So in this study where we looked at kids with isolated penetration on their swallow study, so these were kids that previously would have been said, oh, it's just penetration, we're not worried. We looked at kids that got interventions and thickening compared to changes in flow rates. And what we found was that thickening improved symptoms dramatically, even in kids with isolated penetration. And this was even far superior to changes in bottle flow. So again, I think it's really important to take swallowing dysfunction seriously and have a low threshold for thickening until the kid's swallow function improves. So not thickening was associated with a much higher odds of persistent symptoms. We know based on studies of both high resolution esophageal manometry, which we'll talk about, as well as video fluoroscopic swallow studies, that as you go up on viscosity, you see improvements on your aspiration penetration scores, with thicker feeds showing improved appearance of swallowing. And we see this clinically in pediatrics as well. So again, further evidence that thickening not only helps reflux, but also swallowing dynamics. Now, this all sounds great, but there are some kids that still need enteral tubes. And so sometimes you need to use an enteral tube as a bridge to other interventions, other feeding interventions. And how do you decide if a kid needs an enteral tube? So we use a lot of nasogastric tubes in our clinic. Our preference is always to use nasogastric tubes, particularly if we think the swallow function is going to improve over time. So that is always our first choice. There are some complexities to that, such as they come out all the time and can be a pain to deal with and require a lot of support from a clinical perspective to maintain these tubes with families in partnership. But ideally, we would use a temporary tube. If we have a kid who needs thickened feeds, so blenderized feeds, which we'll talk about, that might push us to go to a gastrostomy tube sooner. Do we need post-pyloric feeding? NJ tubes are really difficult to maintain at home. So if we need post-pyloric feeds because of BiPAP or CPAP, then that's a whole other beast. Although just to kind of say that we do have some patients that are on BiPAP with NG feeds and they do fine, but it just takes a lot of care coordination and tweaking of the calories so that they get their feeds when they're not on their BiPAP or CPAP. So what are kind of the outcomes? So we looked at in our institution on how kids did when we fed them orally versus if we fed them by a gastrostomy tube. And this was an older study. And this was back when we saw an abnormal swallow study. A lot of providers went straight to gastrostomy tubes. So this was right back when we were seeing the switch over to oral, managing aspirating kids with oral feeds. And what we found was that if you feed kids by gastrostomy tube, their odds of needing hospitalization are significantly greater. So kids who are fed orally do better and stay out of the hospital more. So if whenever possible, we will continue oral feeding rather than put in an enteral tube. And this is why if we can get by with an NG plus oral until we get the kids full orally fed, that's our preference. Just we have so much mischief with these tubes. We know from adult studies, and this is just one example, but there's many, that early withdrawal of food, so making patients NPO, results in worsening swallowing decline long-term. So again, just really important to keep the skills going. And even in our kids that aspirate all textures, we still give them a little bit of something by mouth, as long as they're stable enough from a pulmonary perspective, just to keep the skills going. We know that this doesn't result in any adverse outcomes. So this was our quality data here at Children's that has been published in Pediatrics, looking at hospitalization risk and looking at the number of gastrostomy tubes placed for kids who aspirate. We've now hospital-wide, we put gastrostomy tubes in less than 5% of kids who aspirate, which is a huge win for us. When we started, we were, as you can see, some years we were at 20% of our kids were getting gastrostomy tubes. So with multidisciplinary care and aggressive help with oral feeding, we've been able to get our gastrostomy tube rate way down. And despite that going way down, we haven't had a bump in our ER visits or our hospitalization. So the worry when we started this quality initiative was that all these kids would come into the ER with pneumonias or respiratory decompensation. And in fact, what we see is that the kids who are orally fed, which is the blue line, actually came much less frequently and were admitted to the hospital much less than the gastrostomy tube patients. So despite this quality initiative, we still had improved outcomes. Now, I talked about the need for gastrostomy tubes. Sometimes we have to put them in, and that's the only way to safely feed kids and give them most of their calories, if not all of their calories. And so when we use gastrostomy tubes now, really our go-to is to use blenderized feeds, and we use it almost exclusively in our clinic. So this is a study in adult stroke patients, but the data our experience is similar in pediatrics. When you feed a patient a liquid meal versus a semi-solid feed by their gastrostomy tube, you significantly reduce the amount of reflux, which is on the y-axis. So you get much less reflux when you feed thickened liquids into the gastrostomy. And on the right, you have the gastric emptying scan, and you don't have a hit from the gastric emptying. So even though you're feeding very thick things into the G-tube, there's no negative impact on stomach emptying. We also know from a pediatric perspective that outcomes improve from a hospitalization perspective when kids are given blenderized feeds or thickened feeds. In the study from our institution, we improved respiratory admissions as well as total admissions in kids that are on blends. And the use of blenderized feeds for us has really reduced the need for use of transpyloric feeding. So this is a huge win. The kids aren't going to be tied to a pump on continuous feeds with post-pyloric feeds. So again, we're big fans of blenderized feeds. Now, not all blenderized feeds are created the same. And in this study, Dr. Haran and I looked at the viscosities of different commercially available formulas here in the US. And you can see using the IDSI framework, we were able to categorize a variety of different formulas. When we're going with gastrostomy feeds in kids with pulmonary symptoms, we will go to the extremely thick category. That's our first choice because we don't want things refluxed up into the airway. And in kids who've had fundoplications or other GI surgeries, the extremely thick feeds are tolerated extremely well. Now, just because you're going to use a blend doesn't mean that you can stop there. The value of the blend is in the viscosity, and we're currently actually doing a study of different viscosity blends looking at health outcomes here. But one of the things that we've looked at in the past is pulmonary outcomes. And just to show you, we used chest x-ray as a proxy for pulmonary health. And what we found was that if you add water, free water, to your blenderized feeds, you negate the benefit of the blenderized feed. So you really want to keep it very thick. And even by adding just an ounce of water to a blenderized feed, you significantly reduce the viscosity. And what we know from this study is that in kids that are getting greater than 20% thin liquids into their gastrostomies, their rate of getting chest x-rays was significantly higher as a proxy for pulmonary disease. So we typically will run our kids much drier than we will patients without pulmonary disease. And then the other thing that we do is when we need to give liquid, we give it in the form of fruit puree or thickened water rather than just thin water. So again, just a really different practice shift for us on how we manage feeding intolerance and pulmonary disease. And then just to mention some adult data, I know I've been kind of harshing on cow's milk protein, but in this study of adults looking at elemental formula and the development of aspiration pneumonias in adults with neurologic impairment, they found that patients who were on an elemental diet had improved pulmonary outcomes compared to a standard liquid diet. So frequently, in addition to using blends, sometimes we will use elemental blends. So now you can have peptide-based blends, for example. So lots of things to think about when we think about nutritional management of kids with aspiration who are fed by gastrostomy. And then just to remind everybody, transpyloric feeding, we love transpyloric feeding, but blends have really kind of gotten rid of a lot of our need for it. But in this study looking at fundoplication outcomes, which is the dotted line versus the solid line for GJ tubes or transpyloric feeding, outcomes are the same. So if we don't have to permanently change a kid's anatomy by doing anti-reflux surgery, we're going to try to buy time as best we can with transpyloric feeding, with then ultimate transition to oral or transition to gastrostomy tube feeding. So when at all possible, we really try to avoid fundoplication. All right, so what's new and hot? I just want to spend the last little bit showing you kind of what I think is the most fun part about where we're going with feeding disorders in kids. So I want to talk a little bit about high resolution manometry, which is how we measure swallow function in kids that we're worried may have dysmotility. And I'm going to talk a little bit about how we do these studies. So just to orient you, the top of the screen is where the kid's head is. The bottom of the screen is where their stomach is. Anywhere you see yellow or red is high pressure. Wherever you see blue is low pressure. The upper esophageal sphincter is this band of high pressure here. When a patient swallows, it relaxes and opens and goes to blue. And then you see this yellow peristalsis, or the wave, pushing the food down into the stomach. And then at the same time as the swallow is happening, your lower esophageal sphincter opens up and lets the food into your stomach. The reason this is so cool from a pediatric feeding disorder perspective is this technology allows us to look at different types of food in kids. So for example, we test cookie, where you can see here the squeeze of the esophagus going down with cookie is a lot better with liquid. The child drinks liquid and there's like no yellow squeeze of the esophagus at all here. And so this allows us to differentiate how swallow looks with different textures without relying on radiation, which is an advantage to the technology. It also lets us see what happens with deglutitive inhibition. So what happens when kids chug things, like chug a bottle, for example. When you do rapid swallows, what's supposed to happen is on your last swallow after you chug something, you get peristalsis going down. And this is what it's supposed to look like. But what we're seeing now in kids is when you really stress their esophagus, you can get swallow, and then nothing. You don't have any peristaltic wave coming down. And so, for example, this would be a type of a swallowing disorder that we previously might not have seen. And this is the type of kid that you, for example, may need to pace, right? Because if you're not seeing any peristaltic waves as clearance, that could be troublesome with food sitting in their chest. The other thing just to mention is on high resolution manometry, we can also diagnose rumination. So just to remind everybody, rumination is when the kid's stomach contracts inappropriately and squeezes and pushes fluid up into the esophagus and the mouth. And these kids look like horrible reflux, and they'll describe that they're refluxing 20, 30, 40 times during a meal and after a meal, and need to spit this up either into a towel or in the sink or whatever. And the way you diagnose this is high resolution manometry. So this is the same type of tracing. You have your upper sphincter at the top, your lower sphincter at the bottom. But what I want to highlight here in the square is you can see it's pink, and then there's like a lighter, well, a linear pink, I don't know, lighter, darker, but you can see a stripe of pink here and a stripe of pink here. This is what happens when the stomach contracts and it pushes fluid up through your lower esophageal sphincter. Wherever you see pink is fluid. So your stomach contracts and then pushes this pink up into your chest. And this looks like, for all the world, like reflux. But you can put all the antacid you want on it and it's not going to help. The only thing that's going to help this is either motility meds to try to empty the stomach faster, or thickenings to make it so hard that kids can't push it up into the esophagus. So again, just thinking about alternative diagnoses. And then lastly, I'm going to end with this new technology called functional luminal imaging probes. And this is at the time of our first endoscopy in kids with swallowing issues. We have a catheter we put in the esophagus and we inflate the balloon in the esophagus. And what this is simulating is what would happen if like pizza got stuck in the esophagus, right? Your esophagus would get really mad and start contracting and peristalsing and squeezing. So this is a poor man's way to do a motility screen while kids are under anesthesia. And I'm going to show you what the video looks like. So on the right here is the 3D reconstruction of the esophagus. I'm going to start playing the video. This is what happens when the balloon is inflated. You can see here at the top the volume in the balloon. That's kind of the pizza getting bigger and bigger. And then what you're going to see happen is the esophagus is going to get to a point where the balloon is so big that it's going to start to squeeze, which is what you're seeing here. So you're going to start seeing these contractions moving from the top of the esophagus going down, and you'll see it on the 3D recreation as well as the balloon's going up. Here, we're going to see another contraction. And just for the sake of time, I'm going to zoom you forward a little bit. So again, you're seeing a squeeze coming down, and then your lower esophageal sphincter opens up as the squeeze is coming down. And this is what you see, back-to-back contractions with the esophagus trying to remove the balloon. So again, a really nice guide. If I saw something like this, I'd say like, this is great. The tools are there, the nerves are functioning, the muscles are functioning, I'm going to be a lot less worried about this kid's swallow. In contrast, this is what it looks like when things are not so great. And I'm going to just zoom forward because this is very boring. You're inflating your balloon, you're at 39, 40 milliliters, and you see nothing. You see no squeeze at all. So this, if I saw this in a kid, I'd be really worried about their long-term prognosis, right? Because you're not seeing any functioning squeezes here and no relaxations of the lower esophageal sphincter. So again, just a really nice new screening test for swallowing dysfunction that we're hoping will be able to correlate with feeding outcomes soon. So I'm going to go ahead and stop there. Just to summarize, feeding difficulties are more than reflux. Do not use proton pump inhibitors. Do not use proton pump inhibitors. Shout out to all of the registered dietitians who are amazing, because a lot of creative nutrition solutions are needed to treat medically complex patients. And then think about dysmotility. It really matters. And we're just more than run-of-the-mill reflux. Think about esophageal dysmotility, think about gastric dysmotility, and how you can try to tease out the causes for feeding dysfunction. So I'll go ahead and stop there. Thank you guys for having me.
Oh, thank you, Rachel. That was just a fantastic talk. You're getting lots of questions and lots of excitement in the chat box. So I'm going to start with a few of the questions. A lot of questions about thickening you'll be pleased with. So Kathy was asking that she's read studies on hydration and thickening. Do you feel that thickening does not detract from hydration? I think this is especially relevant for you because you're reducing the free water.
Yeah, this is a really big issue. And I have to tell you, we've gotten so much pushback on this part of our care. So we had to do home monitoring of specific gravities to convince people that the hydration status was okay. Initially, when we started this, we were checking electrolytes on kids. There are studies in animal and humans, basic science studies, looking at hydration status and extracellular hydration status, showing no impairment with thickening. So we are not worried about it. And in fact, it seems that when kids get on the appropriate level of thickening, they actually end up eating and drinking more because they're not getting waterboarded. And so they're just much more comfortable drinking. So in our experience, we haven't seen it. Now, every once in a while, you may have a kid who just doesn't like thickening, and then I can't keep them hydrated because they hate it. But that would be the only reason that we've seen downsides to the hydration.
And Colin was asking, are there considerations for also what to do with oral meds when patients are on a thickened diet? I know you touched on that, but can you tell us if you're routinely thickening all the meds for your patients? Yeah, so if there's signs of aspiration of thin liquids on their swallow study, we will thicken all of their meds. And then the question is how. So for example, omeprazole, if you're going to prescribe it, is a notorious beast to thicken. So some meds just will not thicken. Our preference is with cereal or with purees as our first choice. But if we can't, because it's still too thin, we will use commercial thickeners for our meds if we need to. But if you aspirate thins, you're going to get your meds thickened. Okay. And Morgan is asking about your thoughts on what thickeners to use for children under 1 year of age, particularly if they're preterm. And another person had asked about if they're breastfeeding. Yep. So really good question. So as you guys probably remember, we used to use Simply Thick all the time below the age of 1. And then there were some case reports of necrotizing enterocolitis with the use of Simply Thick. So at our hospital, we use Simply Thick for kids over the age of 1. For kids under the age of 1, we use Gelmix and PuraThick as our go-tos. Sometimes we need to use other ones. But again, we're a little bit cautious because of the necrotizing enterocolitis case studies. So in collaboration with our speech language pathologists and occupational therapists,
they will ask for medical clearance. So if there are some conditions, well, I will not budge on commercial thickeners. So if they have a history of Hirschsprung's disease, if they have cardiac disease that has results in potential impairment of blood flow to the gut, I will not use commercial thickeners. I'm going to try to find some kind of food-based thickener in kids under the age of 1. For breastfeeding kids, we love breastfeeding. We totally support breastfeeding, but there are some kids where breastfeeding is not, it's not the right thing because of their risk to the lungs, in which case then we highly recommend families pump, and then we use commercial thickeners in the pumped breast milk to try to keep the swallow safe. We would much rather use pumped breast milk thickened than use an NG to give breast milk, because again, we really try to preserve oral feeding at all costs, and we want to preserve breast milk use in all instances. So for those, we will use commercial thickeners, and that's our only option for breast milk is commercial thickeners.
Okay, and are you delaying the use of thickeners for preterm babies because of the neck concerns?
Yeah, this is a big conversation. This is a big topic for us, and we debate a lot about what to do with a preterm infant. So the Simply Thick guidelines are 42 weeks post gestational age for use, which we will use, but it's tricky, right? Because the kids in the NICUs, what are you going to do? So many times the kids will get sent home with an NG from the NICU. And then as soon as they hit that age, then we will start the thickeners in the outpatient setting. So we will work aggressively outpatient to get them once they get to the appropriate age. But we think a lot about the preterms, and if we can delay it, great. So for example, there's some anti-reflux formulas like Enfamil AR, that when you concentrate it, it actually becomes a different thickness. And so we can get by without needing, for example, commercial thickeners by concentrating AR, for example.
Okay, so I know we're running up time to close out this session, so we will close out, but I know lots of other questions, so we're going to go straight on to those. Great. So Morgan, Louise and Kat, if you can stay, we will go straight on. So okay, so we're going to wrap up the session now and move on to the percolator. Just remember, please consider subscribing to our community of practice, which is available to all healthcare providers. And very importantly, this talk will be posted on the community of practice. So please let your colleagues who weren't able to come today, but you think would love this talk, know so they can go and see it. And that's an important place for us to basically enhance our collaborations to enhance and improve our care for children with eating and swallowing disorders. So we'd also like to promote an up and coming Edmonton Pediatric Dysphagia Symposium on Friday, July the 15th, which will have a great lineup, as you can see here, of international and local speakers. And we will send a link to the registration in the chat window for everyone. It's very important on the next slide if you can share your feedback with us and any other ideas you have for future webinars, please send them to the survey link that will also pop up, and it's already there in the chat room. Okay, so we're going to move straight into our percolator. And I think I'm just going to say, Vanessa, because we'll just move straight into this, that please contact us on peas.project@ahs.ca if you have any other feedback, if you have any specific questions that you want to pass on, or ideas for webinars, because we're looking for those. And I'm just going to go straight into the next questions, if that's okay with you, Rachel. Thank you so much. Everyone's so excited. I have questions too that we wouldn't get to if we weren't having this extra bit of time you've given us. So the next question also from Morgan was about your thoughts of off-label use. What are your thoughts of a thickener use for dysphagia for preterm infants under 1 and off-label use? So again, discussing the risks and benefits. And then she has a question about PPI use.
Yeah, I mean, it's always a risk benefit. And what we know, what we say to families, and we talk about all of this, we talk about the neck data that it's been reported with Simply Thick, hasn't been reported with the other commercial thickeners. We, stress if you see any blood in your stool, if the baby's not acting right, please, let us know. Knock on wood, we have not had any adverse outcomes related to use of thickeners in kids under the age of 1, and we hope that continues. But we are very upfront with the potential risk versus benefit. I think it doesn't take long to have, when you have an NG, to say, oh my God, I need this thing out. And so if given the choice of thickeners versus an NG, oftentimes people will say, I'll try the thickeners because managing this tube at home is troublesome. But like I said, we've been lucky that we haven't had any adverse outcomes from the thickening.
Yeah.
And then there was a question about the NG and do we use PPI? No, we don't.
Okay. And then I guess her question here is also, do you think, is there an argument, so coming from Morgan, who's an SLP, is there an argument that decreasing the acidity of acid is less harmful to the lungs? What do you think of that argument?
Yeah, actually, that's a great point. And the data actually doesn't suggest that. And in fact, it seems that non-acid reflux may be just as bad, if not worse. It looks like there are other gastric things in other contents of gastric fluid, such as pepsin and bile, that are both equally as crummy for the lungs at a neutral pH as compared to an acidic one. And the more we're learning, the more we think that it's the other components of gastric fluid that are more harmful to the lungs than the acid. So I would still hold off on acid suppression.
That's important. Now, Louise is asking, how commonly is high resolution manometry used in hospitals? And I guess you have to tell us a bit about your practice that might be different.
Yeah, so if we have a video fluoroscopic swallow study that raises any questions about a cricopharyngeal issue, we will do a high resolution manometry. So if we're worried about upper esophageal sphincter relaxation issues, or the old term of achalasia or discoordination, then we will do a high resolution manometry. If we have kids whose pulmonary disease is out of proportion to their GI symptomatology, we will do a high resolution manometry. So there's many times where we get consult on the inpatient consult service and they say, the kid's turning blue because of the GI. They're turning blue because and I'm like, it's not the GI tract. I'm telling you, it's not the GI tract. We will often use high resolution manometry to rule out any GI causes for mischief from a lung perspective. So then people can move on to other diagnoses. We get a lot of fixation on it's the GI tract on our consult service. So high resolution manometry has been helpful to undiagnose things. And then in older kids, especially if we're considering things like connective tissue disorders, high resolution manometry is very helpful because many times we have feeding disorders or dysphagia as the initial presenting symptoms. So that's when we would think about it.
I have to tell you, I'm very excited about your pharyngeal manometry. I mean, I know that's not really out of the research kind of realm just yet, but I think that has huge potential to help us differentiate reflux from oropharyngeal dysphagia, which I think clinically we're all struggling with all the time.
So true.
Yeah. Okay, so Kat wanted to ask, do you have strategies in your clinic for teaching families to be consistent about their thickening?
Yeah, that's such an important question. So we teach our families to IDSI test in the clinic. So everybody learns how to test, is their formula or breast milk the right consistency? And I don't know if you guys do that in your clinics, but if you Google IDDSI, you can pull up their videos and you can see how you just put the formula with the thickening into a 10 cc syringe. You time it for 10 seconds. You see how much is left in the syringe at the end. And you can figure out the textures based on a variety of their different materials that they have online. So that has been very helpful for standardizing things. And it's also very helpful to see what they're doing at home, if it's the right texture. So we'll say in our clinics, bring the formula or bring the beverage that your child is taking, so we can see it. And then we test what they've been giving at home, because many times they think that they're doing X, Y, or Z, but it's not. So that's very helpful to test it real time. And the same thing that goes with blends. So we ask them to bring their blends to clinic so we can see how thick the they are as well. And then again, just to kind of highlight the key, like how important speech language pathologists and occupational therapists are, because you can thicken all you want, but if you can't get it out of the bottle, you have a problem. So just making sure that your feeding teams are all working with the families to try to do the observed feeds to make sure they can efficiently get the formulas out of the bottle is key.
Yeah, that was one of the advantages for us of the PEAS project, bringing experts together and really pushing using IDSI. And now we're actually, for everyone's information, going to create some videos about blenderized diet, which will include that so people can see. So you have a couple of questions from Rabin Pasad, wondering if, staying on the same theme, wondering if you ever use blenderized foods post-pyloric, and then moving to a different theme, what pro-motility agents are you using for rumination?
Yeah, so all good questions. So let's do the blend post-pyloric. We do use blends post-pylorically. The complexities of the tube clogging are not small. So when we're choosing post-pyloric blends, we're going into the thin category or the slightly thick category if we're going to run into J's, just because we don't want to clog them. But we're totally excited to use blends post-pylorically, and as long as you can avoid clogging the tubes. And sometimes you have to write for a combination. So when you're doing post-pyloric, but then you want to transition them, you do post-pyloric thin blends and thick blends into the G. So sometimes you have to write for a double formula.
Yeah, I do that. I must admit, I've never used them post-pyloric, but I like to do that for families to use a combination with gastric. Yeah.
That's
okay. So Heather has asked, and I think one of the things I loved about your talk today is you're talking about not giving up oral feeding, and that has traditionally been something our Aerodigestive clinic had pushed, but they've moved away from, is that giving up oral feeding. So what does aggressive oral feeding support look like in your practice? Asked Heather.
Yeah, it's complex, and as you can imagine, it varies based on family. Some families have very good supports in their town to help support us in our message, and to work with families on a weekly basis. So if they have early intervention, which is our birth to 3, and we have a speech language pathologist who's willing to work with us, that makes us the most happy. So we know we have regular touch-ins with the family. But in our clinic, we have 2 speech language pathologists who work with the families on each visit. And then we regularly interface with their local providers if they're not us. Otherwise, we have now feeding nurse practitioner visits where they may not come back to see the whole team, but they come back for regular visits with the nurse practitioners and the SLPs to work with incremental increases in feeds. The other advantage is telehealth has been a huge benefit for us because it does give you the flexibility to check in more regularly at home and do observed feedings at home. It's not quite the same as being in person, but it's given us some flexibility.
Yeah, that's really nice. I think that is important for us as well, because sometimes it's difficult to fund observed visits at home, and I think telehealth gets around that issue. So everyone's still getting keen about thickening. So Min wanted to ask, do you have a list of thickeners that you use to thicken different formulas? And I know you published on this, so maybe you can share your resources.
Yeah, so it's constantly changing because, so it's funny, we have like every couple of months, like a cooking session in our clinic where we reevaluate how things thicken because the formulations of the formulas change a little bit. And same thing, so we're big yogurt thickeners. We use a lot of yogurt as a thickener, and the formulations of yogurt also change regularly, including the non-dairy yogurt. So I wish I could give you something fabulous like a recipe book that we use, but we're constantly changing it because of the different formulations. So if you have specific questions, feel free to reach out to me if there's in particular a formula that you use a lot of, and we can give you our current state of things. But we have a very long list going.
Okay. And another question from Karen. Alengate seems to be a popular thickener in Europe. Is this something you've used?
Yeah, so that's a good question. So if you're worried about reflux and you don't want to use proton pump inhibitors, alginates are a very reasonable option to think about. We don't typically use them. They're not available in the US for us, so you'd have to order them online. Not that that's a barrier anymore, but they're just not available to us. The concern in younger kids is people report occasional, rare bezoar formation from alginates. But honestly, we don't use them here because we don't have them.
Mm-hmm.
There's some naturopathic alginates that people are trying to market here in the US, but we don't have any experience with them.
Okay. So we'll group a couple of questions about motility. So Victoria wanted to ask, can you elaborate a bit more on the use of pyloric Botox? And there was another attendee who asked what is causing the low motility, and I think they may be related. Yeah.
Yeah, so it's hard to know. In medically complex kids, it's the poor motility is multifactorial, and sometimes it's related to the surgeries or their placement of gastrostomy tubes, or scoliosis, or some of the other neurologic underpinnings that they're experiencing. From a motility drug perspective, our preference now for upper tract, for gastric motility, we still use erythromycin, not to treat reflux, but to treat dysmotility. Prucalopride, if you can get it covered, but insurance is a beast here, is my most favorite, but I can't get it a lot of times. And the pyloric Botox for us is relatively easy, but again, easy to give, but insurance, it's very expensive, right? The kids need anesthesia and they need an endoscopy to give it. And then the Botox is frequently not covered because there's no randomized pediatric trial. So I feel like in pediatrics, we're a bit paralyzed and we're using everything off label. But prucalopride is my most favorite drug, and Botox, if I'm doing a scope anyway, makes sense.
Okay. Now, Victoria also wanted to ask about cow's milk protein allergy and delayed reflux symptoms in childhood. So with that in mind, do you recommend delaying the reintroduction later than a year of age because of this?
Yeah, that's such a good question. And I'm nervous now, right? Because everyone used to delay, and then we started seeing all the anaphylaxis and development of other allergies. So I don't delay. I just keep an eye for symptoms. And we will still continue to introduce it when we feel that we can safely do so. And that may be less than a year of age. It may be at a year of age. But we sure are watching closely for any mischief. And if we need to think about an endoscopy or pulling it out again.
Yeah, I had sort of a related question, because I've seen you present a number of times talking about the use of amino acid based formulas reducing reflux, and I also wonder about that. Is there a risk that we can increase allergy by doing that? So how do you decide to use them versus other things like thickening, including with yogurt, right?
Yeah,
so
right.
Yeah.
Oh, such a good question. And what I can tell you that what we are is very aggressive about early allergen introduction when we're doing purees. So kids, for example, with oropharyngeal dysphagia, we're introducing purees at 3 to 4 months of age instead of waiting till 6 months of age. And so we're starting allergen introduction very early for all of the other allergens. So we make it through the list and then get back to dairy sooner rather than later. So we are pretty aggressive about that. And yeah.
Yeah, and there's another challenge for you. So with the research you presented at the beginning, you stated that reflux events don't coincide with symptoms, but what if it's not the events, but the inflammation or esophagitis that results from the events?
Yeah, I think this is a really good point. And I think I know this is controversial depending on where in the world you practice, but this is why we really try to scope early so we see what's going on in the esophagus. Because if the esophagus looks great, I don't want to treat. And it gets very murky when you pre-treat with proton pump inhibitors and H2 blockers, and then they're still symptomatic, and then you go and scope and it's normal, and you're like, well, I don't know, maybe it's normal because they were just treated for 8 weeks with antacid. So I would advocate, if you think there's significant enough inflammation to cause symptoms, you should look and make sure that's the case.
Yeah, fair enough. Okay. And then okay, so Anna was asking, I work with a lot of infants who have consistent and significant pain with reflux, and this leads to aversion. Would you not consider PPI use to improve pain? So I guess, you know, an underlying question there is the premise that the pain is being caused by reflux, if you can comment on that.
Yeah, it's extremely rare. I mean, like extremely rare for that to be the case. And much more typically for us, we see horrible discomfort with feeding and things like that. And it's more that they have aspiration that was missed. And if we just got the swallow study, we would find that and correct the swallowing dysfunction. And a lot of the like head turning, back arching, spitting up after a feeds is often kids trying to protect their airway. And so you just have to get the right diagnosis. And so I would argue that, you know, try to look a little bit more rather than kind of blaming the reflux. Yeah,
I think that's a really important take home of your talk today. Now, I was very excited to hear you're going to do a study looking at different blended diets and their viscosity. What is your opinion about commercial blends? I have to confess that I always had, and the dietitians who know me will know, I'm always saying, look, that's not blenderized diet. They're not as thick as blenderized diet. But yet the dietitians tell me over and over again that they do work for some patients. So where do you fall in that discussion?
I think blenderized feeds, homemade blenderized feeds are awesome, but they're super labor intensive. And with the pandemic, it's been very hard to get the ingredients that you need to make sure that those feeds, you know, encompass everything that you need them to be. So we actually do use commercial blends, especially, for example, the thicker ones, the real food blends, for example, the complete pediatric organic blends, those are thicker. Or we use a combination. So I'm big into rotating. So sometimes, you know, you'll use a home blend, sometimes you'll use a commercial blend just to kind of mix it up from a microbiome perspective. The only thing just to keep in mind is I think there's some complacency about commercial blends, and even on commercial blends, we've seen some deficiencies of micro and macronutrients. So you just have to make sure that whoever's prescribing the blends continues to follow up with a registered dietitian or your gastroenterologist, just to check in to make sure that you're not getting into mischief from a vitamin perspective.
Yeah, and I think that also speaking to your idea of rotating them, we've actually seen carotenemia with some blends, right? So when if you're rotating and increasing that diversity, you can maybe get away from some of those complications. Okay, there is a couple of questions. Dr. Posada asked what are your indications for doing Botox, you know, aside from when you're going down to do an endoscopy?
Yep. So this gets to the question about the rumination that I realized is in the chat too. So if I think there's a rumination, I'll consider Botox, especially in young infants. I can't do behavioral modification in an infant for rumination. So anything to improve gastric emptying, it would be helpful. Any kid with retching. So the question about, does reflux ever get so bad that it causes aversions? Well, not reflux, but retching. So there's nothing more miserable than that. And Botox will abort the retching very frequently. So that would be a really good indication for Botox, is to abort retching. And then last thing is volume tolerance.
Yeah, that's very interesting. We haven't done that. We'll often do everything we can and then move to GJ feeding. So maybe that's a step we need to think about, Rabin. That's a new idea for us. So Andrea is complaining about the length of time it takes to get a GI consult in Alberta, which is fair enough. So she's saying, you know, if you're a community OT and you're SLP and you're seeing these kids for months and months before they can see a GI doc and have an endoscopy, what general strategies would you advise them?
Yeah, I mean, I think if you can empirically thicken, I think that is great. What we debate here, and we have this debate every week, is if you're going to empirically thicken to what? Do I go to mildly thick? Do I go to slightly thick empirically? And I think that is always the tricky thing, because we can't tell based on our clinical feeding evals. So, you know, I mean, I always say go thick, you know, or go to the hospital. So, you know, going thicker is always good. So I think empiric thickening is what I would say. It's rare for us not to be able to control reflux with thickening in this day and age. So even while you're waiting for GI, and that will not muck up your endoscopy at all. So I think that's a huge win.
Yeah, and I think the last question we have is that, you know, the association between PPIs and allergy and EOE, is it possible that those conditions were pre-existing but incorrectly diagnosed as reflux?
Yeah, I think that's the key question. And I think that's what people flaw those studies with, is that it's just a confounding by indication, and that those patients, in fact, were predisposed to developing allergies. And that may be the case. It may be the case, but I would argue, why take the risk with a PPI anyway? Even if it is a confounded by indication, what do you need the drug for? They're not efficacious. So, so why take the risk that it might cause eosinophilic esophagitis? I hear you. And that is definitely the problem with all of these association studies. So it's a really important question.
Yeah, but it's also very exciting to see, you know, finally so much research being done in this field, and we owe a lot of that to you, Rachel. So thank you very much, and thank you again for your time. Oh,
thank you.
You've got another quick question if you have 2 minutes. So how long are your patients expected to be on thickening, and what education do you give? Do you tell them how long they can expect it for?
Yeah, so if the swallowing, so for example, if it's reflux, we know they're going to outgrow it by 6 months. So that's our timeline that we typically give. If we're using it for oropharyngeal dysphagia, we know from studies from preterm infants that the majority of infants have outgrown their need for thickening by 6 months of age as well. So that is kind of that sweet spot. Now, if you have anything else thrown in the mix, such as an anatomic reason, or like a laryngeal cleft, for example, or you have any neurologic underpinnings as a cause for it, then that is going to get pushed out. And so you may not know. If what we typically say is most developmental swallowing issues should have been outgrown by the age of 2. So if this is developmental, we anticipate that they will be off thickeners by 2 at the latest. If we start getting to that 18-month mark and we're still on thickeners and we can't wean, then we really have to think about what other diagnostic tests do we need to think about at that point.
Okay, so we'll have last 2 questions, because everyone wants you to stay, but we'll try and wrap up in time. So what are your considerations for children, you know, with hypertonia and genetic conditions, when you're thickening and it makes them less efficient? How do you manage that?
Yeah, I think that's a really fair point. And I think, you know, this comes down to what alternative ways can we feed. So for example, we frequently will feed formula in a pouch. We thicken formula up to a pouch consistency. We will use open cups. We will feed formula by spoon if we need to. So there's many ways to improve efficiency. It just may take a different method of feeding to get that efficiency back. And sometimes we can't do it, but it's the safest thing. And that's where we think do a combination of some oral feeding. Maybe it's not the most efficient, but the rest goes blenderized into the tube. And I think that blenderized feeds really let families continue to feed, you know, whatever else the family is feeding, plus whatever's efficient orally. I mean, I agree. You don't want to have meals last an hour for sure.
Yeah. And lucky last question. Are you recommending, when the question is it GERD, are you recommending that all these patients get a scope prior to a PPI trial?
Not necessarily. So we recognize that not everybody has access. And so I think using an H2 blocker is totally reasonable to do, and it won't impact the scope if there's, for example, proton pump inhibitor responsive eosinophilic esophagitis. So the fear is that the PPIs much more than the H2 blockers. So if you feel like you think acid is the problem and you want to try something, I would much prefer an H2 blocker over a proton pump inhibitor. And, you know, if you need to push the H2 blocker dose higher, and and then, you know, while you're waiting. But I would really try to scope. If you think this is bad enough that you need meds, I would try to scope in advance. If you can't, you try a PPI trial, but do it for as short as possible. Do 2 weeks, just 2 weeks. If the symptoms aren't improved, then move on to something else.
Okay, well, thank you very much. We will wrap up now. Again, you can contact us at peas.project@ahs.ca. And we want to thank you again, Rachel, so much. I've been so excited to have you come for so long. So this has like made my day, my year, I think. And please fill out our survey, everyone, so that, and give us any other ideas you have about future webinars. And we will finish now. Thank you so much.
Thanks, everybody.